in May this year to conduct the Commonwealth Health Professions Alliance, the Commonwealth Centre for Digital Health and the Commonwealth Medical Association, under my leadership, took the role, a leadership role in this. And we talked of strengthening health systems using digital technologies in the midst of the COVID-19 pandemic to ensure universal health coverage. So you can see all the partners who came together here for this very important advocacy event, which was held as a virtual event. And if you are interested, it's on our website. You can use the link to go and take a look at those deliberations. The outcome of that was a policy brief. But briefly, the background that led for us to move into this advocacy work was that the Commonwealth civil society noted that digital technologies is one of the 7 accelerators identified by the WHO for health systems strengthening, especially in the context of pandemics. Second, we realized that understanding how these technologies can be used effectively and strategically to mitigate the effects of pandemic to ensure universal health coverage is vital for all countries. And as a result of the COVID-19 and virtual functioning, new ways of doing things have been shown to be very effective and potentially more cost effective. And there was then a particular opportunity, a window of opportunity. Then thirdly, our objective was to discuss these issues and formulate a civil society policy brief for the Commonwealth Health Ministers, international development partners, and intergovernmental agencies. So this is what we embarked on. And while doing this, we realized that there were potential benefits and opportunities in the use of digital technologies in healthcare. And these are listed here. And I won't go into details because I know in the technical session today, lots of these things will be repeated and discussed. Then we also realized there were challenges and risks in using these technologies. Again, those are listed here. And in the interest of time, I will not go into details because there will be longer discussions during the technical sessions. With that background, identifying the potential and the challenges, we came up with 4 recommendations for the Commonwealth Health Ministers. And these were the recommendations. So we requested the health ministers to request the Commonwealth Secretariat to working in partnership, such as the Commonwealth Centre for Digital Health, to conduct a study across all Commonwealth countries to map the use of digital technologies in health services and medicines delivery, and so on. It was so vital that we do that. And as you saw, the Commonwealth Centre for Digital Health has taken the initiative in January this year itself to start off with the Commonwealth Digital Solutions platform. We also requested the Commonwealth Health Ministers to mandate the Secretariat to work with individual Commonwealth countries at their request to provide technical advice in integration, acquisition, and use of digital technologies into their health services delivery and continue professional development of their health workforces. This was also another very important area that we identified during our civil society forum. Moving on to the other recommendations, these are listed here. And we again urge the health ministers through the Secretariat to explore opportunities to cross-Commonwealth collaboration in use of digital technologies in healthcare, with a view to establishing a Commonwealth social business coalition in digital technology, leveraging on best practices. And this is today's discussions can feed into this type of conversations that we are having now. Then fourthly, we also urge the Commonwealth Health Ministers through the Secretariat and their Human Rights Unit in collaboration with Commonwealth Association to take take the lead in calling for development of models of regulation, policy stand for use of digital technologies in health delivery. This is so very vital today in the context of all the discussions that we are having in terms of privacy, security, equality, human rights, and so on. So this is another recommendation that we made. And then, of course, we called on the Commonwealth Secretariat in implementing these recommendations and recognizing the cross-link between effective delivery of health services and related social services, explore ways to ensure integration and interconnectedness in digital technologies across sector. Obviously, health does not sit by itself. It cuts across social services, education, and other sectors as well. And the Commonwealth is a truly global platform where we can explore these. And this is the other thing that we recommended. These recommendations went to the Commonwealth Health Ministers' virtual meeting in May in 2020 and was recognized there. And they were incorporated in two recommendations that went into the final outcome statement of the Commonwealth Health Ministers meeting. And we hope, as the Commonwealth Commonwealth Centre for Digital Health, working in partnership with the Commonwealth Secretariat, to take these initiatives forward. And it would be a pleasure for us to collaborate with COMSATS as well as all other partners who are here today in the virtual meeting for us to go forward. So with those words, I would like to once again thank COMSATS for organizing this very important meeting. And I'd like to thank all those who are participating from across the Commonwealth. And I would like to say that we look forward to working with you in the months and years to come. Thank you very much.
Thank you, sir. I request Dr. Mohammad Salim Raja, Deputy Secretary, Ministry of Science and Technology, Bangladesh, to express his views. Sir, please.
Mr. S.M. Junaid Jahid, Chairperson, Commonwealth Centre for Digital Health, His Excellency High Commissioner of Sri Lanka to Pakistan, Honorable Secretary, Ministry of Environment, Sri Lanka, Honorable Chairman, BCSIR, Bangladesh, Distinguished Chairperson, Commonwealth Centre for Digital Health, other guests and audience. Assalamu alaikum and very good morning. I would like to convey my thanks and gratitude to COMSATS and Commonwealth Centre for Digital Health, CWCDH, for taking this type of initiatives. I also want to express my heartiest congratulations and acknowledge my gratefulness for inviting me. Now, the whole world is facing a traumatic time due to COVID-19 pandemic. It affected our health, our economy, and I think on everything of our life. Especially the developing South Asian countries are facing trouble more in this pandemic. Total system have been changed and we are in threats always. In these circumstances, I do believe, of course, we shall overcome the problem if we do work together. Government of Bangladesh has taken various initiatives in digital health service, and the practitioners, doctors also taken this type of service like government, government of Bangladesh introduced apps to identify the COVID patient, and they arrange quarantine and isolation at the beginning of the of this pandemic. And we have some initiatives like counseling the patients, consultation with the patients, telemedicine service, supply of medicine by pharmacy, build up consciousness among the people, and like that. As a third world country's member, we have a lot of problems regarding digital health system like lack of technological support and knowledge also. Non-availability of smartphone and insufficient electrical support everywhere in this region. Last of all, I think through experience and knowledge sharing, COMSATS member countries would be benefited, and we can exchange our views and experience with this platform. All of the members of COMSATS will be benefited. Now, I am wishing the success of this program. Best of luck. Thank you.
Thank you, sir. I would now request Professor Dr. Muhammad Aftab Ali Sheikh, Chairman, Bangladesh Council of Scientific and Industrial Research, BCSIR, to express his views.
Thank you, Madam. Honorable Chair of today's webinar, Dr. Ganja Khalid, members of Parliament and members of Prime Minister Task Force on COVID-19 Executive Director of COMSATS, Syed Muhammad Zunat Khalid and Zahidi, participants from different centers of excellence of COMSATS, respected panelists and other respected guests. Very good morning. I am delighted and honored to be invited to today's webinar as a guest speaker. Dear participants, I have joined to Bangladesh Council of Scientific Research and Industrial Research, BCSR, last month, and I am still in the process of acquainting national and international affairs of this organization. Originally, I am an academician and have been teaching in chemistry, University of Dhaka as a professor. At the beginning of my speech, I would like to pay humble respect and homage to the soul of the father of the nation, Bangladesh Sheikh Mujibur Rahman, who fought for the betterment of the common rule of the country throughout his life. My humble respect to the daughter of the father of the nation, visionary leader, Honorable Prime Minister Sheikh Hasina of the People's Republic of Bangladesh. I came to know that the webinar has been jointly organized by Commission of Science and Technology for Sustainable Development in the South, COMSATS, and Commonwealth Centre for Digital Health. Beloved colleagues, BCSR has a long time and effective relationship with COMSATS. We have been working as a center of excellence of COMSATS in different fields of mutual cooperation, including fellowship for international resources, joining and organizing international training and seminars, and other fields of collaboration in science and technology in order to achieve the goals of sustainable development. I hope this mutual cooperation will continue in future. Respected scholar, title of today's webinar has been chosen as Digital Health in COVID-19, Sharing Experience of COMSATS South Asian Member States. It is really a burning issue all over the world, particularly in the time of existing global pandemic situation. We all believe that science and technology will show the pathway to get rid of this great crisis and compensate the economic and social loss caused by this pandemic. BCSR has well-equipped research team who are working on COVID-19 related research and development activities including genomic genetic variance analysis must play a crucial role in expanding knowledge on this new virus to adopt measures to control its outbreak. Our genomic research laboratory has carried out 263 complete viral genomic sequence so far, and they are working hard for the next investigation. The government of Bangladesh take necessary and very beautiful initiative to face this situation. Our medical doctor, nurse, and health activists working hard for the betterment of the people of Bangladesh. Finally, I wish the program a great success. Thank you very much once again for inviting me and giving me an opportunity to share few words with you. Joy Bangla, Joy Bangabandhu, may Bangladesh live long. Thank you very much.
Thank you, sir. I would now request Dr. Anil Jayasinghe, Secretary, Ministry of Environment and former Director General for Health Services, Sri Lanka, to express his views. Sir, please. Sir, are you available? Dr. Anil Jayasinghe. Sir, can you hear me? Dr. Anil Jayasinghe is not present at the moment. He'll join later. So we'd like to request His Excellency Vice Admiral Retired Mohan Vijay Vikrama, High Commissioner of Sri Lanka to Pakistan, to express his views. Sir, please.
Good morning, Honorable Minister and other distinguished speakers. First of all, let me congratulate COMSATS for organizing this webinar to discuss how much digital health has assisted the authorities in controlling and managing COVID-19. It also has provided a platform to share the experience what everybody had among others. As you would have known that our first corona case was reported on the 27th of January when a tourist returning back after a holiday was found infected at the airport. The government of Sri Lanka immediately set up a corona task force comprising of health and a cross-section of institutions and agencies mandated to deal with such exigencies. Before the first local case was reported, there was a gap of about 1 month from the time we had the first foreign contact and the local contact. We realized that if this pandemic spread unrestricted, it will pose a lot of problems for a country like Sri Lanka, which was scarce as far as the ICU facilities at that time and the ventilators and so on. The task force was initially chaired by the president himself. That was well suited for us because he chaired the requirements of forecasting health and other requirements could be easily transmitted. The policies were transmitted and instructions to various ministries, departments, and agencies tasked in controlling and treating the pandemic. As done in other nations, Sri Lanka also had a 52-day lockdown and a stringent contact tracing procedure with a very effective quarantine arrangement. By 30th of April, the authorities in Sri Lanka managed to curb the community spread of the virus. Today, as we have some doctors speaking from Sri Lanka, I do not want to tell too much of that story. We had parliamentary elections, which was delayed due to COVID-19. and was conducted under strict health guidelines. On the 5th of August, about a month back, and we had about 75% of voter turnout. And in Sri Lanka now, all the activities are almost near normal. COVID-19 troubled our economy like most other nations. The hospitality sector that employs approximately 500,000 persons and the large informal sector suffered the most. The garment sector, the small and medium industries were the next badly affected. The government of Sri Lanka had to commit about 50 billion rupees, approximately $270 million, as a monthly grant of 5,000 each for approximately 7.5 million persons across the country for the 2 months we were under lockdown, that is April and May. And the Central Bank of Sri Lanka supported the affected companies in monetary easing with suspension of loan payments for a stipulated period and a concessional refinancing program of 50 billion to the affected companies. 6.71 million of our population of 22 million use the internet. And the number of mobile phones in Sri Lanka exceeds our population. In complementing this digital health, I think we used the cyberspace effectively, and I'm sure with the assistance of COMSATS, in disseminating information to the public and also controlling and treating the pandemic. I'm not a technical person to tell you as to how it was done. I'm sure during the technical sessions, the doctor representing Sri Lanka will probably tell you how it was done there. Ladies and gentlemen, it is increasingly becoming clear that the post-COVID-19 world will be different from what we were used for centuries. Status of economy, the social order will undergo obvious change. While some countries will gain, some will experience intolerable losses depending on how each country handled the pandemic. The social landscape has already changed in both developed and developing world. Most people will not fully grasp the scale, the scope, the pace of the impact of this on their individual lives. Although a large amount of research is carried out so far, we have not got a clear signal of a successful vaccine. Of course, we have got some amber signals now, but it has to be declared by the World Health Organization. And we'll say if it is successful, it will take a long, long time before it reaches the poorer societies in the world. Even mass vaccination, many people will avoid public interaction or travel. Hospitality and air travel industry worst hit by the pandemic will suffer more in days to come until public confidence and trust is fully restored. Non-formal sector that was worst hit during the lockdowns will take a long time to fully recover. Unemployment will accelerate the vicious cycle of poverty. SOPs such as mask, social distancing, and hand sanitizing has come to stay among the communities for some time. Unless the developed world stand together with the developing nations and help in reviving the global economy with debt relief and generous economic assistance, the global poverty situation will further aggravate during and after COVID-19. We have seen how Pakistan has worked its own strategy in dealing with COVID-19 successfully. Similarly, each country will deal depending on its internal and external factors unique to each country. Finally, I must say that no country is going to be judged by the number of COVID-19 deaths it has had, but how it has come out strong economically after the pandemic. Thank you very much.
Thank you, sir. Now I would request Dr. Sania Nishtar, Special Assistant on Poverty Alleviation and Social Safety to the Prime Minister of Pakistan, to deliver her keynote address. List of Dr. Nishtar's achievements is rather long, which range from founding the well-known NGO Heartfile to serving in various executive positions at home and abroad. It is her commitment, perseverance, and acumen that has earned her acclaim at national and international levels. Ma'am, please.
Assalamualaikum ji, can you hear me? Hello?
Yes.
Assalamualaikum, can you hear me there?
Ma'am, can you speak a little bit louder?
Am I audible at your end?
Can you speak a little bit louder?
Can you hear me?
Yes, we can.
Okay, all right. So let me begin by thanking COMSATS for convening this event. COMSATS has been a leader in technology in the country, and their contribution in technology actually predates COVID. So they have a very long-standing contribution to further the cause of technology in the country. I also want to thank them for focusing on the Commonwealth and focusing on health systems in the South Asian region, because countries that are in the Commonwealth actually have a shared imprint of the British, the beverage style healthcare system on their health system. So whenever we talk about reform or prescriptions to reform the health system in the Commonwealth, it resonates with the countries, the discussion that countries are having resonate with each other because their health systems were formed on the same blueprint. And this is specifically true of South Asia. Now, I have for a very long time held this view that all the countries that, you know, in terms of health systems, if we have to think about reform, then technology is one of the most disruptive tools that we have. In fact, back in 2010, I had authored a book called Choke Pipes, in which, rather than describing the 7 pillars of a health system, the 6 pillars of a health system, I described 7. And at that time, people were telling me, well, it is unnecessary to describe 7 pillars of a health system. But now, I think everybody appreciates that it is so very crucial to actually think of technology not just as a disruptive tool, but as a pillar of the health system. So today I'd like to share with you very briefly the Pakistan's experience to COVID. As you know, Pakistan focused both on the health issue as well as the social economic fallout with equal attention. The strategy that Pakistan espoused was multi-pronged. We had a 1.1 trillion package, which was multi-pronged. This was focused on health on one side, and it was focused on the economic side on the other hand. So on the health side, we focused on disease containment. We increased our testing capacity from 450 a day to 800,000 within a matter of weeks. We increased the number of labs from 3 to 128. And alongside, we ramped up our health systems capacity on many fronts. And all this was enabled through multi-sectoral national governance and coordination across all levels of the government. On the other hand, we also focused on the economic side. And on the economic side, there were a number of steps that were taken, but the one that I'd like to focus on is SARS emergency cash, because in that particular intervention, we brought the digital capabilities fully to play. And the implementation of those digital capabilities allowed us to actually roll out an intervention which was quite unprecedented for the country. So I'm trying to share my screen with you here. If you can just bear with me for a minute. screen with you to demonstrate to you some features of the program. Are you able to see my screen now?
Yes, ma'am.
Okay. So basically, ASAS is the new program of the government of Pakistan, in which there are more than 140 policies and programs targeting different segments of the disadvantaged populations. It's, I beg your pardon, we are experiencing some technology issues at my end. I beg your pardon, we are experiencing some technology issues at my end. Is my voice still audible?
Yes, ma'am, it's audible.
Okay, I'm unable to share my screen with you, but I will just continue to talk. So basically, I wanted to share the experience of ASAS Emergency Cash with you because that is one of the interventions that we rolled out in response to COVID, during which digital technologies were fully brought to bear. And as I said earlier, this allowed us to roll out the largest social protection program in the history of the country, through end-to-end digital capabilities. The reason why I bring this forward is because this was not just a social protection intervention, but this was also a welfare and health intervention. The background of this initiative was that Pakistan has 24 million individuals who are breadwinners either through their ability to earn daily wages or earn piece rate remuneration, or are employed in Pakistan's informal economy. 24 million individuals translates into, when seen in the context of household size, this translates into more than 160 million individuals, which is 2/3 of the country's population. That's a very vast number. So when COVID struck, what we basically saw about 2 weeks into the COVID crisis, 2 weeks into the lockdown, what we basically saw on the streets of Pakistan, in our cosmopolitan cities, and there were swarms of daily wage workers for whom life had suddenly come to a standstill. They didn't know how to feed their children because of suspension of intercity transport. They couldn't go back to their rural villages, and they were just out there on the street. Thanks to Pakistan's civil society, who provided them rations and food, but that was only for a few days, and the government had to step in with assistance. And I remember that there was so much desperation about 10 days into the lockdown that people used to call and tell me that we go out on the street with our cars full of bags of ration, but we are attacked because there's so many people wanting those rations, so many people who are hungry, that we are absolutely we absolutely don't know what to do. So that was the situation 10 days into the lockdown. And of course, the lockdowns were necessary, but the lockdowns were a desperate measure for desperate times. So about 10 days into the lockdown, the government stepped in with an emergency package called the ASAS emergency package. ASAS, by the way, is the Urdu word for compassion. And as I mentioned earlier, we have a very large social protection program targeting different segments of the society with initiatives and programs for poor people, for poor women, for orphans, for widows, for poor students, for those who require medical assistance, for poor laborers, for poor farmers, and so on and so forth. And as part of this program, which we constructed over the last 15 months, we have developed a set of capabilities which we were able to bring into play virtually over a matter of 2 weeks to design a new program. This program had a resource envelope of over $1 billion, and it was mandated to reach 16.9 million families. And in the context of household size, this was half of Pakistan. This was half of Pakistan. It was the largest social protection program ever designed in the history of the country, and it was totally turned around digitally end to end. So let me quickly explain to you what were the capabilities which we brought into play. And if I had the slides, I would have shown to you, the visuals as well, but let me try to describe in the absence of the slide. There were 3 things that we meshed together to develop SARS emergency cash. Firstly, there was a digital biometric payment system which we had procured over the last 1 year. And so through a competitive process, we had brought 2 commercial banks on board. And over the last 1 year, we had signed agreements with them to disperse payments based on biometric verification of individuals. That was the first thing that we brought into play. The second thing that we brought into play was a digital request seeking system. Now, in Pakistan, we have a database, and every individual has a unique identity number. And that unique identity number is linked to your passport, your travel history, your taxation status, your ownership of cars, your bank accounts. It is tied to employment status. And we had, over the last 1 year, been experimenting and developing a model to ascertain if people sent us their identity card numbers through SMS, would we be able to tie this to their socioeconomic status by linking them to different databases? So that's the second thing we brought into play. And the third thing that we brought into play was basically a data analytics mechanism. So in that data analytics mechanism, the unique identification number is run through various databases. And based on this, we had actually exited 800,000 individuals from Pakistan's social protection lists over the last 3 years. So there were these 3 standalone things, and we meshed them together to design a SARS emergency cash. So what is it that we did practically? Practically, we ran an advertising campaign, a communication campaign, and we asked all individuals in the country, in this huge country of 200 million people, we asked all individuals to send us their national identity card numbers if they thought they needed help, if their if they had suffered a job loss during a COVID, or if they were economically stressed. So within a matter of about 3 weeks, during which this SMS scheme was on, and it was called 8171. So every Pakistani now knows what 817 is. And we received 139 million applications through 8171. Once we received these applications, and basically these applications were just CNIC numbers, national identity card numbers, SMS to us. Then we ran them through the databases. There were over 15 databases through which these CNICs were run. And at different levels, automatic messages were sent to people. So if a government servant SMS, they would get a message, you are a government servant. And because we had the ability to tie everybody through a family tree, if the wife of the government servant would SMS, she would get a message, your husband is a government servant, you're not eligible. If the daughter would SMS, they would get a message, your father is a government servant. Next, we would run it through another database, that would do the wealth profiling. Another database that would check their eligibility status with the tax authorities. Another one which would check their status through the immigration system to ascertain if they had traveled internationally. And at every level, there were policy decisions on who to check as eligible, who to check as ineligible. And there were a number of wealth proxies that we used. We've recently released a report which outlines the entire design of the program, and I will ask Dr. Junaid and Ambassador Fawzia to share that link with all the colleagues, given that I cannot share my slides with you. So at every level, messages used to be triggered, and then people used to be put in a queue. So amongst the cohort of 16.9 million individuals who were eligible, we used to stagger the SMSs which enabled them to receive the payment. Because of COVID, we didn't want congregations in one place. So the individual would, the first tier of messages would be, you're eligible, you are uneligible. The second tier of messages to them would be, you can go and collect your payment at such and such site and at such and such place on such and such date. And then people would go, and all through the length and breadth of the country, we had thousands of cash payment campsites and locations and bank ATMs where these disbursements were made. And on our digital screens on a daily basis, we used to see how many people have received the payments, how many people are remaining, and the remaining ones then we would send repeat messages to. We had constant surveys ongoing. We put up a digital information system. It was a search engine through which all the members of our parliament they were all in their constituencies, helping set up camps, helping mobilize people, helping with financial literacy. Our district governments were helping, our security forces were helping. And this was a very profound experience during COVID when the entire country was shut. It was a very profound experience to have these massive cash operations on ground. And our survey, which we are going to release very shortly, basically shows that more than 90% of the utilization of this money was for subsistence, was for food rations, because 2/3 of the country was virtually not earning, and their dependents were not earning, and they were able to take back the money, buy rations, and sit quietly at home. And we believe that that along with the disease containment strategy, that this intervention, which was totally digital end-to-end, was quite transformative in helping Pakistan achieve the success with COVID, which is with great humility, I have to say, is now internationally recognized. For us, Asas Emergency Cash changed the way we will deal with government, at least to the extent of my ministry, because we have gained very valuable experience in deploying large-scale programs in a context of uncertainty with speed and with agility. This experience has forced us to do things in a very new way, to leverage digital technologies, to leverage whole of government capabilities through digital convening mechanisms. It's truly changed the way I think we will run government in the future to the extent of my ministries. It has made the government more agile, more experimental, more digitally driven, more cost effective. But this experience has also shown us what the limitations of digital technology are, and what you need to do in terms of digital literacy if you have to leverage these technologies going forward. So even while this program was halfway along the line, I published a report to share this experience with an international audience. That report is available, and we will share the URL with you. In collaboration with our embassies and our missions in Geneva and New York, we are constantly holding sessions to share what was done, what the limitations were, how we're evaluating it, and what the plans are for the way forward. And we'll be very happy to ask COMSATS to engage the Commonwealth Centre for Digital Health in these conversations as well. So thank you very much for asking me to be part of this conversation. I hope that this will be the beginning of many other conversations and experience sharing exercises. And with that, I hand the floor back to you at COMSATS. Thank you very much for having me with you this morning.
Thank you, ma'am, for enlightening us with the role of digital technology in Pakistan during COVID-19 and particularly a SARS emergency cash. Thank you again for your time. Before I call Dr. Anil Jaisingha, I would like to ask the participants to open their cameras for a picture.
Open the camera.
I'm unable to share my screen. There's some technology glitch at my end, so I apologize, but I'm unable to share my screen. This is Sanya here.
It's okay, ma'am. We'll take for the rest of the participants. Dr. Sanya?
Yes.
Can you hear me?
I can hear you, yes.
I've been informed that you would want to leave the session. So should we continue or you are going to leave the session right now?
I can stay on for another 5 minutes.
Okay, thank you, ma'am. Now I would like to request Dr. Anil Jaisingha, Secretary, Ministry of Environment and former Director General for Health Services, Sri Lanka, to express his views. Sir, please.
Thank you very much. Can you hear me? Can you hear me, please?
Yes, sir, we can hear you.
Okay. Okay.
Yes, sir.
Thank you, the organizers of COMSATS for inviting me to deliver this brief speech. I'm sorry I got late because of a meeting in Colombo. Now I will actually analyze based on the data on 17th last month, because actually nothing much has happened thereafter. Only thing is there were some cases added due to repatriation flights, not the internal cases. So as at 17th last month, the number of cases were 2,895. Right now, today, the number of cases, the tally is 3,123. This means, you know, this is the cumulative figure. And the situation is that we have never had community transition in this country, in Sri Lanka. And if you take age-wise, over 90% of the cases were age was less than 60 years. So actually, basically from children to the productive age group was involved, was suffered. And then if you take the primary cases, by that time, there were 1,045 primary cases, and from those primary cases, the secondary cases produced was 1,617. So I mean, there is no high replication. And then when it comes to tertiary cases, which were produced from secondary cases, it drastically goes down to 233. So that itself shows the way that the Sri Lanka waged the war against COVID in a very rapid manner. And also, we only 12 deaths have been reported so far, and our recovery rate is staggering over 95%. So those are the actually baseline and the results that we harvested. And then now I would say why we were successful in this COVID battle. I think the reasons were due to the strategies that we launched with regard to COVID-19. And if you take the all ports of entries, the measures on ports of entries were implemented very early, and also other actions were implemented very early. In fact, if you take thermal monitoring, I had to visit to Geneva, and on the way forward and back, I didn't see any other airports. You see, the getting ready for thermal screening, whereas Sri Lanka already the thermal screening was in place. And then the very stringent quarantine measures that we adopted, and we had this the disease quarantine and disease prevention ordinance, which was enacted in 1897 in place, and which enabled us to ask for locking down, curfew, and all the measures that we launched. And then the entire country, based on this ordinance, the entire country was declared a disease entity. So that was very useful for our implementation of strategies. Then the other thing was early diagnosis. We are one of the countries that we developed the diagnostic facilities in a country in South Asia. I think we were one of two. We implemented very early, and also our PCR philosophy, PCR application was actually based on more vulnerable, targeted PCR testing. And then once the diagnosis, the separation of cases or the treatment of cases was 100%. No patient was allowed to stay at home or wherever. And then, of course, so similar that way we control, and then we went for exit criteria, and we developed exit criteria, including for tourism. So once the airports opened in future, the tourism criteria, the exit criteria will be on. And now I say the reasons for success. I think the main reason was the leadership provided by His Excellency the President, the Gotabaya Rajapaksa, who was actually always directing us and the discussing with us, and on daily basis he was on the job. So that actually that gave a lot of courage for us to implement. Another main reason is a time-tested, long-grown public health system in this country. And there are many countries where the field workers are not available for this kind of work. So we have public health inspectors, public health midwives, and others, and they are densely in the country. So therefore, we could wage this war through the public health staff. And then, of course, when it comes to the contact tracing, we never allowed contacts to not to be traced, and we traced almost all contacts. And in that case, the state intelligence service technology was very well used, and that was very helpful, because public health services alone wouldn't have been able to successfully do this the contact tracing 100%. And then involvement of the military in quarantine, because we used both home quarantine and the institutional quarantine. We started off from home quarantine and moved into largely to institutional quarantine, where once again the health services are not in a position to develop these quarantine centers in quick time, double quick time. So the military came into the scene once again, as instructed by His Excellency the President, and therefore we were able to quarantine all of them. We are continuing quarantine. In fact, even now, those who come from come through the repatriation the scheme, there are about 8,000 even at now being quarantined. And then, of course, the cooperation that we received from the general public, because if the general public didn't heed to us, didn't work with us, didn't cooperate with us, I think our exercise would have been futile. So basically, just to sum up, we didn't allow community transition in this country, mainly because we didn't allow virus to cross over to vulnerable populations. That means the over 60 years of age, they actually almost didn't get disease. It was less than 5% who were aged. So if this virus was able to cross over to this segment of population, we would have been in a big trouble. So therefore, I can say that the strategies that I mentioned worked very well, and therefore we could harness good results. And now it's about managing the results, managing the status that we have achieved. About actually more than a month ago, we actually came to this the control status. So this is what I wanted to just to discuss with you. Once again, thank you very much for this opportunity.
Thank you very much for all the guest speakers, and thank you, sir. I would also like to thank Dr. Sania Nishtar here for sharing her views and for her time. But before we end the proceedings, I would like to call upon Ambassador Fawzia Nasreen, who is currently advisor at COMSATS, for vote of thanks. Ma'am, please.
Thank you, Melanie, and thank you, Dr. Sania Nishtar, and thank you, His Excellency, the High Commissioner for Sri Lanka, for participating in this event and for sharing their views, and all the other panelists from Bangladesh and Sri Lanka as well. The discussion on digital health, and in particular telemedicine, has assumed added significance in the prevailing situation created by the COVID-19. The economic challenges, of course, are huge for all of us, and particularly for the developing countries in South Asia. And the social consequences of the pandemic have been enormous. It has had impact on the achievement of the Sustainable Development Goals, Goal 3 on health and well-being, as well as digital access and its use, which has now become a priority, particularly since the outbreak of the pandemic. Innovative approaches and adaptability is important more than ever before. I think today's discussion is very important in generating several ideas, and digital health I think is going to be important, keeping in view the projections that have been made insofar as COVID-19 is concerned for the next 2 or 3 years. It is going to stay with us, and we have to somehow basically deal with it. The vaccine, as we all know, even if it is going to be available, I think there is a huge demand, and the need is going to be again enormous. The World Health Organization, I think, has prioritized different categories, which will be basically needing the vaccine on a priority basis, and of course, the health workers and people who are involved in dispensing the health services, their demand, of course, is going to be extremely important, and I think will be given priority for all the other demands. So what I'm trying to say is that what is important for us to find innovative ways of coping with the situation and consolidating what we have already done insofar as our response is concerned and in building resilience of different communities. I think this is something which is extremely important, and I do understand, and we all do understand, that the challenges for the public sector, for the government, I think is something which is very huge, in the sense that you have to deal with multiple challenges that basically are as a result of fallout of COVID-19. So with this view, I think it is important that we all basically participate in such activities and look at ways in which we can share our experiences and learn from the experiences of each other. So today's webinar actually has been organized with these considerations in view. So I basically would like to thank Dr. Sania Nishtal for her very elaborate briefing on how Pakistan basically had utilized digital technology in dispensing with the cash and other support that the community needed in keeping into the socio-economic needs of the communities. So I value the views expressed by her, and I think we all can basically learn from what Pakistan had done and the reports that have been mentioned. We will try and have access to them and provide the links to the member countries. So I am also grateful to His Excellency Admiral Mohan Vikrama for his remarks, and obviously for sharing Sri Lanka's response to the pandemic and the effective use of cyberspace by Sri Lanka in dealing with the COVID situations. My thanks are also due to Mr. Salim Raza, Deputy Secretary, Ministry of Science and Technology of Bangladesh, for representing COMSATS focal point. And I also would like to thank Professor Aftab Ali, Chairman BSCIR. BSCIR is a member of COMSATS, Network Centre of Excellence. My deep appreciation for the support extended by the Commonwealth Digital Health Hub, Professor Vajera Naika, as well for partnering with COMSATS in organizing the webinar. Deep gratitude for his continued engagement with COMSATS on digital health issues. I also would like to thank Dr. Anil Jayasinghe. I think he has elaborated on how Sri Lanka basically dealt with the COVID-19 situation, and his views are valuable to us as well. I also would like to acknowledge and express thanks to participants who have joined from outside Pakistan, in particular Madam Fazila Alauddin from the Ministry of Health of Malaysia, Mr. Najib Al-Shorbaji from Jordan. He is former director of the World Health Organization, as well as participants from the Pacific Islands Development Forum based in Fiji. So my thanks to all those who have joined from within and outside Pakistan. Most importantly, I think I would like to thank the team that basically organized the event, led by Dr. Azima Fareed, and obviously this would not have been possible without the support of the Executive Director of COMSATS. So thank you very much.
Thank you, ma'am. Ladies and gentlemen, this brings us to the end of formal proceedings, and we will move on to the technical session. I would like to introduce our panelists for the technical session. Dr. Anil Samranaika, Director, Health Information of the Ministry of Health, Sri Lanka. Dr. Lubna Yaqub, Specialist Digital Health and Information System at National Health Services, Regulations and Coordinations, NHSRC, Pakistan. Dr. Nizamuddin Ahmed unfortunately had some last moment pressing commitment. Therefore, we are delighted to have a young health professionalist, Dr. Nausheen Jabin from Bangladesh, who has played a vital role in utilizing telemedicine in her country during COVID-19. I now hand over the technical session to Dr. Hasna Khalid, being chair for the session. Dr. Hasna is a technocrat, social activist, renowned health expert, special ambassador to UNHCR for Health and Education for Pakistan, and a strong advocate for women's health. Over to you, ladies and gentlemen.
Can you hear me? Good morning. Hello?
Yes, ma'am, we can hear you.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. I'd like to thank the organizers, Junaid Zaidi Saab, Dr. Azima, and all your team at COMSATS for giving me this opportunity to talk about our experiences in Pakistan for COVID-19 and learn from our brother states in the South region of how we can move forward to address this and other pandemics in the future. Excellency Ambassador, High Commissioner of Sri Lanka to Pakistan, Ambassador Fawzia, and all valued and distinguished participants, hello and a very good morning. This is a great initiative by COMSATS to talk to all of us about our experiences and about the lessons learned. And I think all my predecessors in the talk introducing about COVID have emphasized and reiterated the importance of technological bridges around the health delivery in the COVID response. I mean, I think before we go on to the technological and technical session, I'd like to congratulate each and every one of our member states here that are taking part in this discussion and those who are not, about how we have worked together, how we have come together to fight as a solidarity drive for COVID-19. I think that is now going to be our raison d'etre for how we tackle the health response and how we use telehealth and digital technology to combat this disease, but also maybe future diseases to come. This crisis has been unprecedented and has touched the lives of many people around us. It has come out of this adversity that we are bringing opportunity and building technological bridges and strengthening health systems, as Dr. Sania and other of my colleagues have previously outlined in this meeting. We will leave no one behind, and using technological bridges and IT modalities, we will leave no one behind, and hence address the Sustainable Development Goals. Our region is, we stand in solidarity, and our region is specific because we have a lower patient to doctor ratio. Our total population of Bangladesh, Sri Lanka, and Pakistan, the countries that are today being representative in this meeting, is around 400 million. And our access to healthcare has been difficult. So the universal health coverage issues have been quite pertinent. And if we can find the modality vis-a-vis telehealth and technological bridges, then we will address some of these challenges. The expertise, the intellectual capacity is there. We just lack the coverage, the number of doctors, the number of paramedics, but also the vast instances and the specific geographical issues that we have to get universal health coverage. We need to use our technological advances and the telemedicine network to create early warning systems of the epidemics, both of this COVID-19 situation, but also as a preparedness for other pandemics to come. It doesn't stop at COVID-19, unfortunately. So the Commonwealth Centre for Digital Health, and I think my dear colleague who was representing CWCDH, is extremely important in this whole equation as a linchpin by which we at COMSATS can work together with all the member states, 27 in total, and create a solidarity drive of how we can work together to create a one world, one opportunity scenario to tackle the pandemic response. There will be many things to share, and there will be many experiences to share, both by coming up with different proposals for the vaccine trials that are ongoing in each of our member states, and sharing and coming up with equal health and intellectual exchange, but also we can share research experiences and help each other to come up with data, and data which is larger in depth and number is more useful for teaching other part of the global humanitarian effort for COVID-19. So what is the status of information communication technologies in our countries? Why is it so important? And although overall ICT development index stating of these countries is low, but as my honorable colleague pointed out, the number of mobile phone users in these countries supersedes the population. So we are on a winner. We have the systems in place. And ICT is a fast developing area in this region. We need to use these technological bridges in increasing the coverage of internet to the population and finding digital solutions for long-standing issues in healthcare and agriculture and education. ICT is here to say we need to use it, we need to develop it. So how do we go forward? COVID-19 highlighted the glaring obvious issues with that were visible of how we access healthcare. And that's where I alluded to, out of adversity comes opportunity. So the problems that arose during COVID-19 highlighting limited healthcare showed that there are options available. Lockdowns restricted travel, fear of getting infection from health facilities, but we can deliver healthcare in a different way. There is a paradigm shift in government policies and mindsets to the benefit of digitization of healthcare. We can use telemedicine for initial screening of patients, mapping hotspots for the cases of small lockdown. And with humility, I'd like to reiterate the success story that Pakistan has had in dealing with COVID-19, using geofencing and technological advances in strategic lockdown and geospacing of hotspots of COVID-19, of the virus. So the use of technology for systemized information and data management bridges and brings efficient systems. Use of virtual means for management meetings, as we're doing now, brings us all together. And this is what we need to build on. I cannot emphasize enough that how small the world has become. And we have strengths both in population sizes, vis-a-vis clinical trials, vis-a-vis vaccine trials, to bring and pool results, but also we can use our joint facilities to come up with data and research pertaining to telemedicine and show the rest of the world what is possible. So bringing that in mind, we will close the region's digital divide. Digital inclusion will work towards integration of digital technologies in health and other sectors. And so we are able to divide policies and strategic level of planning as well as infrastructure development. It is a Pandora's box that we will open, but in a positive sense, because the world is our oyster and our region will be the oyster. So all efforts need to be patient-centric. How are we going to deal with the people that we are trying to help and alleviate suffering for? We will triage them, we will give them primary health care, and we will then better be able to decide which clients or patients need specialized tertiary level care. So rather than focusing on bigger and more advanced and complex hi-fi technologies, we need to focus on simple and doable solutions. And the mobile phone is one of them, and we have it. Digital capacity building from teacher or health professionals training using bots and to use and master artificial intelligence is the new way forward. So, hello? Sorry, I had a little bit of a technological glitch. I apologize. So any point from the objectives not touched upon, I will send a URL links of a paper which describes digital health technologies, how they can be implemented to enable health system strengthening. The research is there. We are already doing it. We've been forced into doing it because of COVID-19. We should use this opportunity to go forward. Minimal digital health interventions to be implemented across the board can bring visible change in healthcare, and we have seen it through the COVID experience. So without going on further, I'd like to introduce my panelists to come and give their overview, and then we can have a interactive discussion on how people feel that we can, number one, work together as COMSATS and the other member states within us, and also how we can use each other experiences to strengthen research and development in this field. I'd like to take this opportunity to introduce Nizamuddin Ahmed, who is CEO of Synesis Health Care from Bangladesh, if he'd like to discuss digital health initiative in Bangladesh in COVID-19 context. Dr. Jamaluddin, have I got you online?
Dr. Hasna, Dr. Nizamuddin wasn't able to join the session today. So Dr. Nosheen Jabin is going to represent.
Welcome, Dr. Nosheen. Would you like to give us an overview of your success story and experiences in Bangladesh?
Assalamu alaikum. I'm Dr. Nosheen Jabin from Bangladesh.
Welcome, Dr. Nosheen.
Yeah. So thank you everyone and all the speakers for their very impactful opinion and their perspective. And we have learned a lot of perspective regarding the digital health and its different dimension. So can I start my presentation? Can I get the opportunity to share my screen?
Thank you very much. Yes, we would love your to give us your overview, please. Thank you.
Can you please ensure is my screen okay?
Yes, I can see it. Can all the other participants see it?
Yes, we can see it, ma'am.
Yeah,
lovely.
Thank
Carry
you.
on, Dr. Nosheen.
Yeah. So today, again, I'm introducing myself. I'm Dr. Nosheen Jabin from Chattogram Medical College. And basically today I'm here representing a telemedicine service, a project that was conducted in COVID-19 situation and from an voluntary organization, We the Dreamers. And I want to share my experience with this project. But before that, I want to overview some of the digital health context of Bangladesh. So first of all, in the Bangladesh healthcare, we have already outperformed in many sectors, many South Asian countries in maternal health, in infant and under 5 mortality rates. But still, what we can see, we still have, we still have physician shortage, and we have only 6 doctors for about 10,000 citizens in Bangladesh. And these 6 doctors are not homogeneously distributed. That is, in remote areas, in rural areas, we really don't have adequate doctors. And where in capital, that is in Dhaka, we have 43% more doctors than need. So what we are watching, that we have more than demand doctors in the central areas, that is in capital areas, but we really lack adequate doctors in rural areas, in remote areas. So if we look at this graph, we can see we have very poor doctor-patient ratio and nurse-patient ratio in Bangladesh. So it's of no doubt that digital health and telemedicine service can be a great opportunity to bridging this gap that we have between the urban areas and the rural areas, and providing the immediate and emergency facilities for the rural areas. So digital health, as it has flourished so much in COVID-19 situation, but it is not at all a recent concept in Bangladesh. As we can see, in 1998, an e-health project was introduced by Swinfen Charitable Organization, and I'm not mentioning the all shown in the slides, but I especially want to mention the last line that recently the IEDCR, that is our institution of epidemiology and disease control and research team, has launched 17 hotline numbers for COVID-19 outbreak, and that is to let the people know about the health informations or what to do, the directions about the COVID-19. Here's a table that I'm showing. There are many startups of digital health in Bangladesh. So on the right side, there are the name of the different startups that work on different dimensions and different field of to provide the digital health. So all these are not the startup that started in COVID-19 context. All of these were prevalent in Bangladesh far beyond, far before COVID-19. But as we can see some data that are showing that in 2020, when we have COVID-19, the number of calls, the number of service demands for digital health has increased drastically. If we can compare, it is more about 8 times more than before, than anyone ever in the history of Bangladesh. So as we see this graph, even in February 2020, when we didn't have COVID-19 in Bangladesh, the first case was detected in March 8, and we had community transmission around on April, and we can see the rush of people towards the telemedicine service, towards the service through the mobile or through the internet. They were trying to get the information about the COVID-19, what to do, where to go, and many more, the myth, the facts about many service people were calling for. And it was so much higher than any time ever. That is in March and in April. So again, I'm trying to show that how drastically the digital health service and its demand has risen in COVID-19 context. Now let me represent my organization, where I have worked as a project officer in a telemedicine project. So it's basically a non-profit organization, non-political organization, We the Dreamers, and we have launched a telemedicine service. Until now, we have already served 412 COVID patients in regular telemedicine service. So what are the services that we basically provide? So we provide the doctor's advice and the treatment. So let me explain far better. What we do is that we have a preset pro forma where our patient give their adequate histories and all their detailed histories, and we do keep their records, and we do assess the patient by video call, and different video platforms like Zoom or many other platforms. We assess the patient, we interact with the patient attendant, then we provide the advice and treatment. Not only that, we also provide the regular follow-up to them. That is, in our project, we have a daily round session. That is the patient, it is not a one-stop service. This is not a one-way service. This is a service that a patient regularly from the onset to the end. They get regular follow-up. We do the update, the investigations, we update the treatments. Okay, and along all of these, we also provide the health informations. So health information means different informations about COVID-19, how to go for isolation, how to go for quarantine, what are the steps, what personal protective measures should be maintained, and all of these health information. And beside all of this, we have a research team. We are so much updated with the ongoing research of COVID-19 management and its different aspects, not only the treatment of management, but also we care about its public health concerns, about its preventing methods. Okay, we have preventive methods, and our well-structured research team are very updated. What is happening around the world, what steps are being taken in the developed countries, and we update our policy, we update our guidelines very regularly so that we can help and serve our patient at the best quality way. So again, and finally, the emergency information. That is, whenever patient follow any face any emergency condition like severe respiratory distress or in shock, then we immediately inform the patient where to go, how to seek help, and how to seek help. And so in total, my project is like a whole through combination of all the services that are needed by a patient, a COVID-19 patient, to face this disease confidently, as this is a condition the general people doesn't actually familiar with, and they get so anxious, get so fear and scared of the condition. So we are trying our best in this project to serve our patient at its best. So working in the project, we have seen that we have some barriers that are holding us back to make it, to make it not working as perfectly always. So what are that facts that have, come into light for us? So it was that the people have a limited information and limited ICT access. That is, we have in our population, in our socioeconomic status, the internet accessibility, and then the cost of internet, and always the internet speed is not always remain as feasible as ever. So what happens whenever we are trying to interact with the patient or patient attendant in video calls, some barriers or some interruptions happens, and that really works as a barrier to get the best quality service. The later points I want to mention for the people who lives at the remote site or the rural population, that is, there are not available internet, and they are not even aware that how internet can be made accessible, available, or how can they avail the service. And again, lack of infrastructure support, like if we can say the device, if we can say the other infrastructures that support a telemedicine service, that we really lack. And the fourth one is the lack of motivations. And I can say that people are so much rigid to the preset system. That is, people rarely get out of their rigid mindset of the fact that I can take my service online and it can also be successful. People are too much rigid with their preset mindset, and that actually lagging us behind from making the telemedicine a success, because people are not being people are being reluctant of this service. Again, the final one is the patient dissatisfaction and lack of trust and effective communication. And finally, the lack of digital security in the telemedicine sectors. There are some of the points that that seem important to be noted in this point for me and my project. Finally, I can put some recommendations with what we can make this project more successful and more accessible to many distal and rural areas. That is the expansion of the ICT access, and definitely, as this is an online work, as this is an online service, we need to increase the ICT access. That is, made the internet available, made the devices available, made the people trained about how to use the device, and accommodation of the patient language, their literacy, and their disability. That is, as we know, in many areas there are many people of different dialects, and they really face it a barrier to communicate at many languages. So if we can put our light on this concern, and we can make this patient language and their literacy, or if you can put someone between us to collaborate between the patient and the doctor, I hope this gap can be bridged. And in the third point, increasing awareness and the telehealth literacy training, definitely what I have already mentioned, people need to be motivated about the fact that if the system is built in an adequate way, this telemedicine and the digital healthcare service can also be an effective way to provide a successful service. And the fourth one is the providing training, definitely to the physicians, as we in a medical college are always built in a manner so that we can put this service in a patient in face-to-face interview or physical examination. So in telemedicine, there are some sorts of skills we need to assess the patient or vital signs from distal or remote area. I mean distally we need to assess different vitals or the patient condition. We need to increase our interpersonal skill, we need to improve our skill to communicate with the patient attendant and to guide the patient attendant. So in this sector, I think to make this digital health more successful, providing adequate training to the physician or the persons who are providing this service is very, very important. And the fifth one is the patient satisfaction by ensuring the qualities of health. Definitely, we need to emphasize that we are providing the as much as same as the service that we provide in hospitals. I mean, at least we need to try to maintain that quality. And in the sixth one, development of e-health policies, it actually depends on the government level. If government tries and they try to collaborate in different sectors, it takes it as a multidisciplinary approach, and definitely this digital health service can flourish more and be a success in upcoming days. Finally, I want to end with some small hope of scopes. That is, as we all know, Bangladesh is the 9th largest mobile market in terms of the number of subscribers in the world. I mean, we have a mobile first country, and the mobile use has drastically increased in recent years. So if we utilize this fact, if we want to develop the digital health service by mHealth, that is a mobile service, we can, that has already been flourished a lot. I think we can utilize this fact in a more feasible way in COVID-19 context. Not only that, also in future days where many more challenges in healthcare are coming for us. So finally, I want to end with some words that through close cooperation and collaboration with partner health organizations and the government, we hope to harness the power of technology to help people with access to health information and services during these, pandemic times. So that's all from me. I hope I could represent me well, and definitely I would invite any question if anyone have or haven't understand any point. Definitely please note me. I will try to make it clear again. Thank you.
Thank you, Dr. Nausheen, for your very informative and comprehensive presentation. I think in the interest of time, shall we take questions at the end as a cumulative question and answer session? And with that, thank you. And with that, I would like to invite Dr. Anil Samaraika, I'm so sorry if I pronounced your name not correctly, who's going to give us an overview and apprise us of the digital health initiative vis-a-vis the COVID-19 response in Sri Lanka. Dr. Anil.
Yeah, hello. Yeah, good morning, and thank you very much, the organizers, for inviting us to share the experience. And at this stage, we can call it even a success story if we are not too early. But we have done, as our former Director General presented a few minutes ago, and he was a leading figure, definitely. So he led us to, we worked under him, and I'm as the Director Health Information, we get this digital technology from very early. We really started working on this when we had only one patient. That is, our first patient was reported in January 27th, a Chinese citizen in Sri Lanka. From that week itself, we started getting into this digital the arena. So then from that time, from the contact tracing, from detecting the patients to the management, to if I quickly get into the other end of the spectrum, to even engaging robotic technology in the patient management, and even up to the contact tracing and all in all spheres, including telemedicine, virtually. As recently there's one white paper was produced by the Research 2 Guidance that organization. Even according to there are many areas like disease information, the mapping, and even identifying symptoms, the remote doctor consultations like that. As I suggested, we get the digital technology because we were in the right stage. Because as our country, we many of our health institutions were not the majority, but a large proportion has been digitalized. We have digital health records. So because of that, that was in a way, and we are one country, I think, other than USA, we have medical doctors specializing in health informatics. So I'm in our unit. They are the people actually really involved. Medical doctors, qualified medical doctors, they are becoming health informaticians. So other than USA, we are the only country having that. So I think we have that luxury of having, because our patients doctor patient proportion is rather satisfactory. We are training our doctors into that. So as a health administrator, I did this administrative part with our former Director General and the many other our relevant sections, like we have quarantine section, quarantine director quarantine. So we from the beginning we were able to do even the like contact tracing and even quarantine. We shared all this information digitally. So there were many innovatives, many apps were developed. So as I did the administrative part, I get one of my senior acting consultant in health informatician, Dr. Chaminder Siribadana, to describe the real technical aspect of what the interventions we did. Over to Dr. Chaminder.
Thank you. Can I share my screen? Thank you very much. Are you able to see the slides?
Yes, we are.
Okay, fine. So I'll do the presentation from the point of view of the Health Information Unit. So the Health Information Unit of the Ministry of Health is the focal point for all the digital health activities in the ministry across the board. What are the digital health interventions we deployed during the COVID time? So again, as Dr. Anisamaraka mentioned, this is the white paper from the research to guidance, and it talks about many areas where digital health has been used for patient care. So in Sri Lanka, one of the first things we did was to actually set up this short code hotline. So it's 1390 hotline. This was set up by one of the premier telecom operators with the help of volunteer doctors and other organizations such as Health Promotion Bureau, which is part of the Ministry of Health, mandated for health education and promotion. So with this line, they had about 150 doctors. They were able to answer calls and give health advice and guidance for about 80,000 people in the country. And it was a very successful intervention. And then the Health Promotion Bureau, they upgraded their website, and also they started publishing data on COVID-19 status. So number of patients, the number of PCR tests done, all that was shared with the public very transparently. And they also enabled app developers or website developers, they can use that data to give a better picture to the public. And we at the Health Information Unit also, we revamped our own website, and we managed to give data, information on new guidelines and other stats to the public and the health staff. And during the time, we were able to launch this My Health Sri Lanka app, which we meant actually as a guide for the public, as well as the health staff. And as Professor Vajira Disanayaka mentioned, we actually, at the beginning of the pandemic, we had a very open discussion with all the private and public entities who came up with digital health solutions. So we looked at them and we decided how to move forward with as a coordinated manner, and then we decided on these two apps. One is called Self Shield, developed by the Commonwealth Centre for Digital Health, and the other one, My Health Sri Lanka app, which was developed in collaboration with volunteers and ICT agency and other government agencies. And then we also had this risk areas being mapped. This was an initiative by the Western Province Department of Health, and they they took GIS locations of all the cases and gave a map which shows how close you are to a infected case, and then some risk level also displayed. So then we used digital health applications for triaging and testing. For instance, this remote consultations. So we had quite a prolonged lockdown or curfew period in the country to prevent community transmission of the disease, and then because of that, our routine health services were a little bit disrupted. So as Sri Lanka has so many, I mean, we have about 1,100 health institutions that belongs to the state, and on average, it's about every household has a primary healthcare institution within 3 to 5 kilometers. So we actually did not have, as the Ministry of Health, need for telehealth services, other than provider to provider specialized telehealth services, where we had cardiologists providing specialized advice to our primary healthcare physicians. So because we didn't have a platform, the private sector actually came forward, offered their platforms free of charge. We, as the government, provided voluntary doctors, and I'll actually go into detail about that in a later slide. So the next one we had was on patient transport. So as we said, all the patients, if you suspect they are having COVID-19, they were supposed to call that 1390 hotline, and they are actually directed based on their risk to contact to this ambulance service, where they would come and fetch them to a designated health institution. So all these 1990 ambulance service staff, which is available across the country, were trained and given personal protective equipment, etc., to carry out that work without risking themselves. And the other one is also that in the hospitals, we set up triage areas and provided these closed circuit television facilities to interact with the clients while keeping our health staff safe. So there were other interventions, such as these bedside patient monitoring through certain CCTV installations, and then there were robots developed by universities and certain private entities as well as the military engineering corps. And also we incorporated some decisions about systems to our electronic medical records deployed in the state health sector. So as I said, this telehealth response center, we used the technical platforms of our private partners who came forward and offered their services free of charge. And we had about 105 volunteer doctors. We developed guidelines for them. We conducted Zoom training sessions for them, and this was about 1 month back that we were able to serve about 700 patients, and we through those platforms we were able to provide prescriptions that could be serviced by the local pharmacies. And then the COVID time, a lot of non-communicable disease patients who were frequent clinic patients, they were not able to visit the clinics and collect their medication. So we set up two systems. One is actually we published the directory of all the pharmacies in the country with their telephone numbers, and we requested of their prescription and send it via WhatsApp or Viber to the nearest pharmacy, who would then arrange delivery of medication to home. Or if they were government patients who are being followed up in a government medical clinic, what they could do is actually they could give a call to the hospital, and from the hospital they could actually go through the electronic medical record, see their prescription, and from the pharmacy they pack it, and then is delivered actually by the Sri Lanka Postal Service. So this is a small video. Hope you can see it. It's in Sinhala, but I'll try to give a running commentary. So they give a call to the hospital, and the patient record is retrieved, and then the address is confirmed. So once the record is retrieved, they pack the medicines, and address is labeled and securely packed. These pouches are given to the Sri Lanka Postal Service, and through the Postal Service, it's delivered to the patients. So then the other one that we did was actually this is a DHIS2 based surveillance system, and we managed to actually integrate our DHIS2 based surveillance system with our immigration department expected in the country when flight departs from another airport. That patient manifest, the passenger manifest is shared with the Ministry of Health. Then, based on the risk where that patient is originating, we take necessary measures. So that the integration was done fully by our technical teams. And then once those patients come to the passengers come to the country, some sent to quarantine, and so that information about the quarantine centers, and if they are suspected, about suspects, and as well as diagnosed patients, all information is captured through this DHIS2 platform and is shared with all the relevant stakeholders. And we were able to integrate this platform with our Telecom Regulatory Commission, which is the umbrella body looking after all the telecom operators in the country. So if a patient is diagnosed and that phone number is shared with us, we have the ability to go and see to which tower areas. It's easy for our health staff contacts and isolate them. So we also had another arm where we can look into the availability of personal protective equipment through the platform, and also track available ICU beds so that if needed, we can actually transfer our patients to those ICUs.
Sorry to interrupt. I'm very sorry to interrupt, Dr. Anil, and your wonderful presentation. But in the interest of time, could we hasten? We had 10 minutes per participant, and we have, we have very limited time. So I would be really grateful if we could shorten. No, not at all. If we could just shorten. I'm so sorry to interrupt.
Okay, we have, I think, 2 more slides maximum. So this is about an e-learning platform we set up. All the paramedical staff in the Ministry of Health are trained by our paramedical schools. So, I mean, paramedics are very important during this pandemic, but their training was disrupted by the travel restrictions. So we set up this e-learning platform, a Moodle-based one, and now currently we have more than 800 students. All 17 paramedical schools are actually using that. And as previous speakers also said, Sri Lanka has a very good mobile coverage, about 150 phones per 100 inhabitants, and more than 60% of them do have data connectivity. So we were able to leverage on that and provide telehealth services. And we had existing digital health systems in our state hospitals, so we were able to access their patient records easily because of that. And we also had in-house capacity, as mentioned. We have health informaticians trained in the Ministry of Health, so we were able to quickly develop this DHIS2 platform, and it was shared with the world. So the metadata set is actually globally used currently, and we had a very good private sector who was willing to come forward free of charge for most of these services to be up and running within days rather than weeks and months. And we have a couple of challenges also. One is we need to now ensure that the sustainability of those interventions beyond the COVID time, and sometimes the hardware availability, because all the goods and services others were disrupted by the pandemic, and we could not even sometimes get some hardware equipment. And also people trying to sell miracle solutions. Half of our time was actually taken up to evaluate systems, and only we found that very limited solutions had a contextual value in the local setup. So thank you very much, and very sorry about taking more than the allocated time.
Not at all. Thank you very much for your really informative presentation and giving some interesting food for thought. And with that, I'd like to just give a few housekeeping points. If people, whoever has any questions, in the interest of time, to be able to send them in the private chat, we'll try and address as many of those as possible. I would like to introduce Lubna Yaqub Saiba from Pakistan, from the Ministry of National Health Regulations and Services, to give an overview about digital health and COVID-19 response in Pakistan.
Assalamu alaikum and good noon, everyone.
Walaikum salam, Lubna Saiba. Please carry on with your presentation. Thank you so much.
I would request, thank you, Dr. Saiba. I would request Manahil to please share my slides.
Okay, ma'am, I'll do so.
Okay, briefly, let me introduce myself. I am working as a digital health and information systems expert at the policy unit of Ministry of National Health Services. One of the core function of the health policy unit is to digitalize and strengthen the information systems and digital systems at the national level, provincial level, and district level. Can you please go next? National Health Vision, in National Health Vision 2030, digital health information system and research is one of the core pillars. In 2019, Prime Minister Imran Khan launched Digital Pakistan Vision to enhance connectivity, improve digital infrastructure, increase the investment in digital skills, and promote innovation and technology entrepreneurship in the country. In Pakistan's response to the COVID-19 pandemic, digital health received the attention like never before, and it seems it's going to stay. We have equipped we have a fully technology-oriented equipped National Command and Operations Center established to address the COVID-19 pandemic. Federal government has partnered with National Information Technology Board, Digital Pakistan, and several partners, including social enterprises and university, to ensure access to the digital platforms during the COVID-19 response. Next, please. What initiatives we have taken? We have established a health helpline, that is 1166. And then we have developed a mobile platform to keep the citizens updated related to the coronavirus cases. There was a feature like Radius Alert for the self-declared reflection of the COVID patients for better travel management. There was a pop-up notification for maintaining personal hygiene during quarantine, a chatbot and awareness video features to answer all vital questions of the citizen was incorporated in the mobile platform. Then we have developed a statistical digital dashboard. One of the feature was chatbot for self-assessment in both English and Urdu form. All the air travel scheduled, approved schedules are uploaded over there. We have the press releases, we have the COVID-19 guidelines and events available on the dashboard. This is a real-time dashboard, which is also showing the worldwide COVID-19 situation. The latest information of the quarantine centers, hospitals, testing facilities, and isolation wards are also available on our dashboard. Next, please. Yarane Watan, this is another initiative which provides a platform to connect overseas Pakistanis health professionals with professional volunteering opportunities in Pakistan. This is bringing the diaspora together, filling the health workforce gap in nursing, strengthening the pharmacy sector, supporting vulnerable areas, donation and capacity building. We have also developed a resource management system, which is called a decision support system, that is capturing the data of the COVID and non-COVID hospitals with high flow, low flow, and ICU units with the stocks information as well. Next, please. Tracking, tracing, and quarantine technology was developed to detect hotspots, teleco-based tracking, and current address-based tracing. We have also developed a Pak Nigaban National Emergency Response application, which is allowing users to locate their nearest hospitals, to find out beds or ventilators, and figure out lab conducting coronavirus tests. When a user clicks on the hospital lab wedge application, this is picking the current location by GPS and points out of all pinned hospitals and PCR test labs in the vicinity on a map. This is an interactive map. Next, please. There are some more initiatives which were taken during the COVID-19. Different tertiary care hospitals and primary and secondary healthcare facilities established telemedicine departments to provide timely and continuous support to the outdoor patients, where the dedicated staff, including specialized doctors, IT personnel, and support staff is available for assistance of the patients via internet using Skype, WhatsApp, and landline. Sehat Kahani is another example of providing e-health telemedicine care through engaging female doctors to patients in remote areas. We have launched another e-learning program that is called WeCare for one frontline clinical staff supporting critical care to COVID-19 patients and provide backup support. We are spreading the knowledge pertaining to the COVID-19 pandemic by websites like Ministry of National Health Services website, National Command and Operations Center website, COVID-19 website, National Institute of Health, and Health Services Academy. We are also spreading our knowledge through social media management, Facebook, Twitter, YouTube, and Instagram. We have developed a travel surveillance management information system to enable view real-time data analytics and dashboard of different entry points, real-time information helping our central health establishment and other related departments to make evidence-based decisions. We have also developed and deployed our COVID-19 logistics management information system, which includes configuration management, inventory, warehouse, analytics, and notification. There is also a COVID-19 forecasting calculator developed for COVID-19 inventory. There was a COVID-19 procurement system was developed for National Disaster Management Authority to create electronic purchase orders, manage supplies, update shipment information, and stock received against purchase order. There was a centralized case-based information system, reporting system was established at National Emergency Operation Center, which was fetching the information of the COVID patients from the facility level to the national level. And that information is fed it into our COVID-19 statistical dashboard. Next, please. Okay, what policy and strategy changes made so far? In Pakistan's telecommunication sector, a rapid growth having reached 78% of the country's population with over 165 million cellular users. Of these, 76 million users are connected to the internet via smartphones that are enabled with 3G, 4G internet connectivity. Our policymakers are made aware of digital technologies. We are moving towards development of digital health strategy and framework, which will promote our national collaboration and advance the transfer of knowledge on digital health. This will advance the implementation of national digital health strategies. This will also strengthen the governance of digital health at national, provincial, and district level. This will also advocate people-centered health systems that are enabled by digital health. In Pakistan, there was no health information system, action plan, or strategy. We have developed that and disseminated. Now we have started working on the implementation of National Health Information System Action Plan, which will include community-based and facility-based. Next, please. Okay, challenges. What challenges we are facing? Like infrastructure issues, hardware, software issues. We need to increase the smartphone users and internet connectivity issues, power issues, capacity in terms of HR, financial resources, uh, awareness amongst the community, and um, and sustainability. We do not have any sustainability plan. Beyond the COVID-19 or health emergencies. That's it. Thank you very much.
इन्होंने कोई अभी फाइनल के हमने इधर आके क्लासेस लेनी होंगी हैं क्या कौन है वो हम आए
I am over. Thank you very much.
हाँ
Thank you, Lubna.
कहेंगे हमें इनकी और ये हमारे दे हाँ ऐसा ही
Hello.
हमें क्या टेंशन लेने की जरूरत है हमारा मसला नहीं है
Hello.
रूम्स में इंटरनेट कहाँ से पहुंचाएंगे
Can you hear me?
Yes, yes, Dr. Hasna, I can hear you.
Okay, thank you very much, Lubna, for giving this informative overview. I think we're having some disconnect with the people in COMSATS. Maybe unko awaaz nahi ja rahi hai.
We can hear you.
You can hear us? Fantastic. So I'm not sure what the background noise is, but thank you very much for all the participants and giving this all the technical overview and insights into the COVID-19 response for Bangladesh, Sri Lanka, and Pakistan. I think the overarching challenges, if we can start with the issues, are very similar in each of these countries. And they're largely infrastructural. So we need to work together to try and address how we can carry on with those challenges and work together. I think in the interest of time, I've been thinking that if we can get the participants to send questions via the chat facility, and we will answer them. I think one of the most pertinent questions, and from a research background, is how we can pool the results and the experiences from each of these member states. That is my question to the panelists and also the participants. My personal questions, that how do we gather strength and how do we showcase our results and our COVID-19 research findings to each of the member states, and then use that in publication. So if anybody has any insight onto that, I'll be grateful. Does anybody have any comment?
I think one by one our speakers from each country, they can question this answer. Dr. Nausheen, are you present with us? Dr. Lubna?
I think maybe we're having some technical issues. Maybe the panelists, Lubna, are you there?
Yes, I'm here, I'm listening.
So Lubna, being a fellow member from Pakistan, we would like to use our strengths and perhaps ask the COMSATS team to kindly facilitate, to publish our results and to work together to use the experiences from COVID-19 to build upon further platforms for telehealth and providing healthcare remotely. What would be the mechanisms that we can share some of the data sets involved. And I'd like to put this to each of, so Lubna, Dr. Anil, and Dr. Nausheen from Bangladesh and Sri Lanka. How can we do that? Because that's one of the steps forward.
May I speak, please?
Please go ahead.
Okay, Dr. Ghazna, you must be aware that COMSATS is one of the key stakeholder with us. COMSATS is involved in telemedicine projects, and they have also provided us the technical support in training or health care workers on SRHR. And we are also planning to have discussions with COMSAT if they could provide us the connectivity at the Islamabad level to make Islamabad as a model health care district. We are developing the digital health strategy. Dr. Azima is also involved in this process. And we will be conducting more consultations with the COMSAT and other stakeholders, and we would love to have COMSATs on board. One of the requests would be COMSATs can show their telemedicine model or project to our senior level policymakers, so that we can move forward, how we can pilot these initiatives in the remote health facilities of Pakistan.
That's a very interesting point, Lubna, and I'm sure that we can address that and go forward. My context and my answer sort of query is to our valued participants from Sri Lanka and Bangladesh as well. Can we not pool our results together and publish on, so we can showcase to the world our success stories in terms of telehealth and what we've done already? And thank you, Lubna, because that's a way forward, but we could provide access to each other. That's point number one. We looked at challenges in all the countries, and I think they're roughly the same. My question to my Sri Lankan colleagues are, does any policy exist for Sri Lanka for digital health in your country? And if so, would you be able to share so we can learn from it? That's my question to our Sri Lankan colleagues.
Yeah, we are happy to announce that we have published the National Digital Health Policy, and even this year it is being revisited, and we can definitely share with you and with the region. We published it nearly 4 years ago, and we even we can share but according to the current need, we are revisited the policy, and we can share, because as you know, our international donors like World Bank and Asian Development Bank, even they also query, and we have many projects going on with them, so that the National Digital Health Policy, we are very love to share with you.
That's very kind of you, Dr. Anil. What I want to ask specifically is, are there any, because as I said, the world is a very small place now, and you are a friendly nation, our brotherly nation. We would like to do some collaborative work with you in this arena. So would there be opportunity to work together on, not specifically on a research project, but even, there's no reason why we cannot do specific clinics and use that experience internationally, and use COMSATS to be able to facilitate, because it has the technical expertise to do so.
Yeah, definitely. We can, as this even this particular this seminar, current seminar, involved Professor Vajiru Disanaika, who was spearheading that digital health for education and that area. So there's no issue. As I am representing the health ministry, so we would love to share our experience, especially as mentioned earlier. we are developing this health professionals, medical doctors becoming health informatics specialist. So I think we would love to share all our experience with our brothers and sisters in the region.
Very kind of you, Dr. Anil. Thank you very much. And thank you to all your participants and all the wonderful work that you've done in Sri Lanka. My next question is to Dr. Nausheen. We too have these challenges, Dr. Nausheen, but what do you feel about the current IT infrastructure in Bangladesh? And how do you feel that we can work together to improve so you can deliver a better quality of service to your clients and patients? And do you think that's wrong of me to say so, that there are these challenges? What would be your feelings on that query?
Okay, Dr. Gazna, thank you for the question. First of all, I have already mentioned some of the digital health startups in Bangladesh, those who are working far before COVID-19. And in COVID-19 context, many other telemedicine service in both government and public health sector has flourished. Okay, so, but I have already mentioned some of the barriers that are actually lagging us, holding us back from making it more flourished. Okay, and I have already mentioned many points, such like our internet access and many more points. So I think if we can sort all these issues in a multidisciplinary way, we can make it more flourished. And if we work in a collaborative way in other countries, and definitely with many South Asian countries, I think we can make it more successful and well established in Bangladesh. And I think Dr. Azima was asking a question to me on the chat board, that was, what is the role of young generation, young physician in digital health? So as why I want to mention, lots of young physicians are so much interested in digital health. Even the service that are being provided are most of by the young professionals. So I think if we train the young professional to be skilled in both sector, both to deal the patient in hospitals and to deal the patient in telemedicine, in digital health, they will be more competent to perform better and to make it more successful.
Thank you, Nausheen, for that overview. And do you think the current IT structure of your country is sort of, technologically advanced enough to support further advanced digital healthcare strategies?
Okay, we have some,
Sorry, go ahead.
Okay, we already have some, built-in structure in Bangladesh, but as I have mentioned, this hasn't yet flourished so remotely. Many of our rural areas, rural populations aren't yet getting adequate digital health service. I'm not saying that it's not present. It's definitely present, but not in adequate manner. Okay. So I still think that there are many more scopes and fields to build a lot of infrastructure for digital health.
That's great. Nausheen, we face a lot of these challenges ourselves. And I think the remote areas are where perhaps telemedicine is needed most. So perhaps we can tackle this as a community, looking after the healthcare needs of the South.
We hope so that it will be a success once a day in Bangladesh.
I'm sure all your hard work it will be.
May I raise a question, please?
Please, sorry.
It's Dr. Jamaluddin Chaudhary from Bangladesh. I am just wearing mask because I'm in a car and I'm going to attend a meeting in the Ministry of Health. So just one question to the.
Sure, please go ahead,
especially to the participant from Pakistan. This is because Sri Lanka was having less burden of COVID. So I'm rather interested to know that telemedicine could have helped a lot non-COVID patients during the COVID pandemic situation. And it was actually I don't know whether in Pakistan, whether you could have attended the non-COVID patients by telemedicine or not at the very beginning. Was it possible for you, or they were not attended, or rather you can say neglected rather non-COVID patients? You got my point?
I got your point. May I, Lubna, can I answer this in part, and perhaps you can put in your technical input?
Yes, sure. Please go ahead.
Okay, so in answer to your question, Dr. Jamal, you're talking about the protection cluster, and so, for example, the non-COVID patients like antenatal care, like essential care, which goes on irrespective of the pandemic. And yes, there is room for improvement. There were isolated areas where this has been developed, but as you can appreciate, this is this was unprecedented times, and we're developing a new structure of triaging primary health care, especially, obviously, I'm a gynecologist by training, especially training and seeking care to protection, women, children, essential services that don't stop when there's a COVID or when there's any other pandemic. So in answer to your question, it is an area that we are developing. Yes, it's not perfect, and it is an area that we can all develop in collaboration wherever we are. Does that answer some of your question? Hello? Hello? I think we've lost,
No. Can you hear me? Just telling you, not the emergency patients only, but the non-emergency patients, actually, those who are those who are in need of the service.
That's right, Dr. Jamal. We're talking about antenatal care, which is an elective, or talking about primary health care, which is elective. It's not emergency. So yes, as I said, we have developed strategies to address these areas, and there were clinics happening, but it's an evolving strategy. We will be doing more of it. And it is evolving, not specific to Pakistan, but evolving all over the world. It's a different way how we deliver medicine. I think in the interest of time, if you could just write down other people if they have any questions.
Thank you.
You're most welcome. If you could just write down your questions. There is a question by Dr. Usman Sattar, which I'd like to specifically answer or like to put to my participants. And we've looked at, is there any aggregated or anonymized information of COVID-19 patients from health researchers or agencies to aid them in COVID-19 research or pandemic research? I think this is where COMSATS can excel. We do big data analytics, we do data processing, and we should create some kind, if I can just put a comment, of follow-up strategy to this most excellent meeting that's been convened by, the good offices of COMSATS and the whole team under the auspices of Dr. Junaid. If we can have some follow-up strategy, some email group, so to see how we're going to go further in publications and our success stories or our challenges from our respective countries. And with that, I'd like to close this session, if I may, thank all the participants, thank my, my hosts at COMSATS, especially Dr. Junaid and Dr. Azima, who've made it possible and given me the opportunity to come and talk to you guys and to listen to you guys. And if there's any comments or anything that I've left out, please feel free to input. Dr. Junaid, if I can ask you specifically to say a few words.
Thank you very much, Dr. Razna. It's very nice of you. It's very kind of you that you could spare time for this very important sort of activity. We are really grateful to you. Thank you very much. And I say this is the beginning, and we will take it from here onward. From the COMSATS point of view, if you could spare time, and also Dr. Lubna could spare time this week or next week, and then we can sit together and have sort of template regarding the data collection or the case studies of these 3 countries. And on the basis of that, if we can set it from here to Bangladesh and Sri Lanka, then they can also provide us the data in that very format. And then we have a publication, so that means that will be beneficial for the other countries also. And we would like to send to other SAARC countries or South Asian countries as well. I would like to thank all the participants, especially the speakers in this very technical session. Myself being a non-medical professional, I could get what these people have been doing and how the technology can help in developing the outreach of the medical profession. I would like to thank my colleagues here, Ambassador Azir Nasreen, and also Dr. Azima Farid for organizing, and also other colleagues who have been working behind the scene, like the IT persons, like the technical people, and I would like to thank all. And similarly, our thanks to the people in Bangladesh and Sri Lanka who have really contributed to this one. And this is the beginning of this very activity, and we would like to take it further. As you have mentioned, that COMSATS is an intergovernmental organization, and we'll be very happy to work in this trilateral sort of arrangement of the countries, and we will be working also there. Thank you very much, Dr. Rizda. It's very kind of you, very nice of you. And we'll meet again here in persons here so that we can find out the modality to proceed further. Thank you very much.
Thank you, Junaid Saab. That's very kind of you. And I think out of every meeting, there should be a way forward, and you've very, very articulately coined the way forward. So we will touch base with yourself and organize a time, and then we'll be in touch with our our honored guests or our honored participants from Sri Lanka and Bangladesh to also get them on board and create some meaningful research and some meaningful patient-centric.
Excuse me, please, ma'am.
Yes, sure. Sorry.
Yeah. I want to ask some kind of question. So can I ask from this webinar? Through this webinar?
Can I just, sorry, what's your name?
Memuna Taj.
Mamuna, can I just ask you, in the interest of time, I've been a terribly bad chair. I've overrun it by 43 minutes. So if you don't mind, we will be getting back to everybody. If you can just put in a private chat, I would be really, really grateful. Thank you. And I'm sorry that we can't answer it now, but we will get back to you.
It's okay. Okay.
Thank you.
Okay. Right.
If there's nothing else that anybody would like to say, may I seek permission to close this webinar and thank all my participants, my guests, and also my hosts at COMSATS. Thank you very much. And as Dr. Junaid said, let this just be the beginning. Let's work together.
Bye-bye.
Thank you.